When we find something in the central veins, which is an abnormality, whether it's a stenosis or whether it's an occlusion, there have been attempts to try to repair these to improve the blood flow. The two main options have been stenting of the stenosis or angioplasty, with or without stenting. The problem we run into is both of these groups will tend to have multiple subsequent interventions necessary to maintain the patency. These slow flow vessels just tend to stenose or thrombose. And also with these two techniques, there's really no difference in the primary or secondary patency rates that have been shown for the fistulas once these therapies have been performed. Now, moving away from stenosis or occlusion, we're going to change gears and look at large competing veins. These are most important in the first 10 centimeters, so as you come from the anastomosis into that early draining vein, you need to look whether there are large branch vessels which are drawing flow away from the main vein. This is because the vein needs an adequate amount of flow to create a shear effect to allow the vein to dilate. Pay special attention to the caudal portion of the arm, or sort of in the stick zone where you would be placing your hemodialysis needles. So moving from a large competing vein, we're going to look at the third abnormality that may occur. In this case, the draining vein is too deep for consistent vascular access. Although the diameter of the vein is 8 millimeters, which is well above our 4 millimeter threshold, it is greater than the 5 millimeter depth that is easily accessible. Again, this is most important within the area where the hemodialysis needles will be placed. Just another example in the cephalic vein in the forearm, where we have a small draining vein, but look how deep this is, over 6 millimeters deep. I think most nurses would have a difficult time trying to access this vein. So when we have one of these three abnormalities, whether it's a stenosis, a large competing vein, or a vein that's too deep, often there are attempts to try to correct the abnormality to improve the likelihood of successful dialysis. Notice that the AV fistula adequacy rate is typically lower in women. They have smaller veins, and only about 31% are initially successful. Also, the success rate is worse in the forearm, which also has smaller veins. Because women start off with a lower success rate, salvage procedures actually work better for them. They may cause improvement in 50% of women, whereas men improve in about 37%. Notice the final overall success rate ends up equaling out fairly closely between men and women. So when we detect an abnormality of an immature fistula, the salvage success depends on the underlying lesion that's causing it to fail. The likelihood of fistula maturation depends on whether or not you use a salvage procedure. If there's a stenosis which is not treated, 0% will go on to be clinically usable, whereas if the stenosis is treated, 70% can go on to mature. If there's a large competing vein branch, 83% will subsequently be usable if corrected. And then if there's a superficialization for a deep draining vein, 71% of these will eventually go on to have a useful hemodialysis fistula. This is an example of a success story of a large competing veins that were fixed. The initial post-op images show a draining vein 2 centimeters from the anastomosis, a larger one at 4 centimeters from the anastomosis, and another one at 5 centimeters from the anastomosis. Notice in this case, the volumetric flow is only 364 milliliters per minute. Now, after ligation of the competing veins, notice how the draining vein has dilated. It's now 6.3 millimeters diameter, and we now have a volumetric flow well over 500 milliliters per minute. Our last topic that I'd like to discuss is the routine screening of the asymptomatic patient with a hemodialysis fistula. Several studies have been performed where they do frequent repeated ultrasounds to detect abnormalities in an effort to try to pick up an abnormality before it led to thrombosis. The meta-analysis included 12 different studies. 4 of these were fistula trials. The screening in these trials did decrease access thrombosis, so less than half of the typical thrombosis rate. However, even though the thrombosis rate was decreased, it did not reduce the fistula loss. So this suggests that the thrombosis may be a marker of the fistula loss as opposed to an underlying etiology. In the 8 graft trials that were included in the analysis, routine screening did not reduce thrombosis rates or graft loss rates. Sometimes when you have a very successful fistula, there may be a sumping of flow of the distal artery, as I showed at the very beginning of the talk. The reversal of flow is taking the blood flow away from the hand or the forearm. Usually these are asymptomatic. However, if there are symptoms, there should be a modified sonographic Allen's test where that the flow from the ulnar artery and the radial artery are checked to make sure that there is a patent palmar arch with collateral supply to the thumb. If the arch is insufficient, and if they're having symptoms, occasionally revision or even sacrifice of the fistula may be necessary. This is just an example of an artery with a reversal of arterial flow beyond the anastomosis. Notice we are above the baseline, and above the baseline flow is headed toward the patient's head in a reversed fashion. Some of the pitfalls that you need to be aware of. I think that it's become pretty standard use that ultrasound prior to fistula creation should be used. It's been shown that if you use ultrasound prior to fistula creation, there is a higher success rate. Inadequate sonographer training is another problem which may limit your ability to do these studies. Once a sonographer has been trained, the training doesn't really end there. There should be constant quality control of the sonographers and of the studies that are being performed. Other limitations which may affect this technique are variability among the physicians in your group, and then also just the inherent intra-observer variability with these studies. One study that looked at the intra-observer variability looked at 24 accesses in successive sessions, and they found out that even within the same session, the variability was 11.6%. This is larger than the variability for the dilution method, which is 7.7%. They noted that there was especially high variation if the needle orientation was altered between the sessions for the dilution technique. Moving away from the macroscopic abnormalities that we detect with our typical ultrasound exams, we're going to consider a couple of the more microscopic abnormalities. Intimal changes in fistulas have been shown. It's been thought to be due to the increased flow through the fistula. However, there is some recent research that suggests that there may be undetected intimal disease prior to the fistula creation. So these may be patients that are predisposed even before they have the fistula placed to failure. Other questions rise whether the arterial inflow or the venous disease is the most important component to the failure rates. And then when we find hyperplasia of the artery, it hasn't really been shown whether hyperplasia versus actual plaques and calcifications have differing effects on the outcomes. Intimal hyperplasia has been associated with stenosis formation, and then there's also preliminary data that hyperplasia itself is associated with fistula failure. Once we go beyond the radiologist and the imaging, the clinicians have tried to see whether or not they could use antiplatelet therapy, thinning the blood to try to prevent thrombosis in these patients. In a randomized trial of 877 patients, there was reduced frequency of early thrombosis in those with the antiplatelet therapy. However, even though the thrombosis rate went down, the proportion of usable fistulas did not significantly change. There again, this is supporting the fact or the idea that early thrombosis may be a manifestation of the failure rather than an underlying etiology. Even farther away from radiology, we should look at potential for genetic markers. If hyperplasia is an influencing factor, then we should look at whether or not there are genetic markers for the hyperplasia, such as listed below, to help predict which patients may have a worse outcome. So in summary, hemodialysis ultrasound is very useful for the monitoring of patients with abnormal hemodialysis fistula maturation. We can detect stenoses, competing veins, and draining veins that are too deep. Whereas screening alone may not be very successful, the early identification of abnormalities suggests that we can improve these fistulas with early salvage. Thank you for your attention.